Yes. All right. So let's move to the patients who are, for whatever reason, not going to be transplanted or not eligible for transplant. And so I just show a little bit of data on that. So the first thing I wanted to show is that actually there are a lot of choices because patients who are not transplant eligible technically could also have a range of options that could be offered to them, including even to think more closely about the possibility of transplant. And so we have several different kinds of data. We have the 2-drug combinations, we have the 3-drug combinations, and so you can see the various choices there. I put red boxes around the ones which are maybe the more frequent choices that we have right now. Although I realize in Europe that MPT, for example, is the approved choice. So what should we say about the choices? I think that a powerful data set was presented at ASH, which showed the comparison between the Revlimid Dex for a continuous treatment until progression for 18 cycles versus what is the standard and approved MPT regimen, which is the 12 cycles. And so clearly quite decisive results from this very large study. You can see 1,623 patients, so a huge study, I think one of the largest myeloma studies ever conducted, with clear improvement in progression-free survival, improvement in overall survival, and what was quite interesting was the very, very low level of the hematologic SPMs in the patients receiving RevDex as a frontline option. So we have those rather clear data. Now, in addition to that, we have studies that were presented at ASH, actually both from Antonio's group, looking at the comparison of the 2-drug regimen versus 3-drug, both for the Rev low-dose Dex and also for the Velcade. And in each case, you can see that the 2-drug combination was performing rather well and also with lesser toxicity with the 2-drug versus the 3-drug. So efficacy rather similar, toxicities and less, so that you have here a choice of possibly using a 2-drug regimen for the elderly patient. But then we have some more new data presented at ASCO and EHA, Maria V, showing the long-term follow-up with the 3-drug regimen, and not the MPT, but the VMP. And it was extremely interesting, and this was discussed at our recent IMWG summit, that the longer-term results out to 8 years with VMP is really pretty impressive, both for PFS and for overall survival. And so here we have good benefit with a 3-drug combination for the elderly patient. So, what do we recommend in the absence of transplant, where we would be looking to not consider it and just focus on this approach? So, maybe we won't start with Antonio first. Maybe, Ola, what do you think about this?
I think you outlined all the answers to the question here. I think you have the 2-drug, you have the 3-drug, and I think Antonio has pioneered the field looking into the elderly, I think, in terms of trial development, drug development. And I think he has told us from his studies that looking at age alone is obviously not the right thing to do it. You have to look to see how fit the patient is. And for those patients who are in very good condition, they may be able to tolerate the 3-drug combinations, and they probably have the same good outcome as younger patients do. While for patients who are less fit, maybe you have to scale back a little bit, and I think the 2-drug. So if you ask me what therapies I would pick, I would probably pick the type of therapies we talked about for the transplant-eligible patients, for those fit patients that are older. And for the less fit, my preference would probably be RevDex in the US. That would probably be my choices.
Right. So maybe I'll go to Antonio. So have we interpreted what you've been telling us correctly? Is this a correct interpretation?
No, I think this was not only our experience. I think, first of all, we have to start thinking on the elderly subject, not only in terms of age, but much more and more and more in terms of comorbidity. So the two parameters must be put together. There are some scores, there are different ways to do it, but certainly two parameters needs to
And this is something that we haven't been doing, to use like the Charleston comorbidity index, something like this, which we don't use routinely right now.
Because this is very, very important to reduce the risk of toxicity and to some extent to define. Then I completely agree that we should have a free drug combination for the fit and move to the two drug combination for the elderly, and probably move towards the proteasome inhibitor if we need a fast, active response, and give the IMIDs when the disease is less aggressive and symptomatic from that point of view. The other concept is the continuous treatment that is certainly also coming and was coming clearly by the study of Terifacon that presented at the plenary at the ASH, where the continuous treatment is the one that is making the difference in terms of remission duration.
Right. The arm number A, where the treatment was until progression, was clearly the most beneficial. Yes. So how does this fit with the practice at the Mayo Clinic?
Yeah, I mean, I think it fits well. I think what we're demonstrating is multiple myeloma is multiple myeloma. I mean, patients can be so variably different, but it's in particular in the older population, as Antonio said, and as Ola has mentioned, it's not just this is your age, therefore you get this drug. I try to look at all of those variables and say, do I think the patient needs to primarily get a lenalidomide-based regimen or a bortezomib-based regimen? Meaning the bortezomib generally, if it has to be a bit more quickly, and also convenience to the patient. Sometimes it's going to be much more difficult for them to get a therapy that involves an injection as opposed to a pill. But then within those, I also want to comment that not all 2 and 3 drug combinations are the same.
Right.
So if you, for example, add
Well, I certainly
melphalan
showed
and
you
Revlimid,
VMP looked pretty good.
correct, but if you add melphalan and Revlimid together, those are 2 tough drugs to put together.
Right,
so,
NPR.
Correct. So the NPR. So, I said earlier that you're the champ until someone knocks you out. I'm going to suggest that maybe melphalan is not necessarily the champ anymore in older patients. That it's not necessary to use. That it could.
After 20 years, we finally follow.
Yes, exactly. Yeah. That's right. They're finally going to follow our lead. But where cyclophosphamide could be, for example, I wouldn't think of Cybor D as a very heavy, if you will, 3-drug combination in an older patient. And what sometimes can help, whether it's with lenalidomide or whether it's bortezomib-based combinations, is dose adjusting a little bit based on age and comorbidity and other things to make sure that it's a bit more gentle. Because the last thing we want to do is to give too tough a regimen to an older patient and end up having so many challenges with low blood counts and toxicities that they end up having to come off.
But one other thing that came up at this summit that we were just at is that we had a very elegant presentation from Jesus San Miguel, who pointed out to us maybe some differential efficacy of the IMIDs and the proteasome inhibitors related to the cytogenetic, to the FISH findings, the 414, the 17P, the 1Q+. Do you think we should be considering this in the choice?
I mean, we wrote M-SMART, so I have to support it. But yeah, where we do.
Well, you did mention it so far.
Yes, I was the lead-in question. But I think what we learned was if a patient does have the translocation 414, they're more likely to benefit from a proteasome inhibitor.
Right.
If a patient has standard risk disease, I think they have more options that you could go with either. I think what we're not really too sure is in that highest risk group of patients with P53 deletion, it's still a little bit unclear what is the best for them. In our M-SMART guidelines, because we don't really know what to do in that group, we often suggest that they get both a proteasome inhibitor and an IMID. Get a proteasome inhibitor for 414, and then standard risk, they can get either of the two. But we know that's open to interpretation. We don't have extraordinary data for that. But I do think it's one of those variables that must be considered when a patient is diagnosed, because it does influence, the treatment does influence their outcomes.
So can I ask you, Antonio, so that if you have a 414 patient and you would use 2 drugs, maybe if you have 414 you might use Velcade Dex instead of Revdex? Would you consider something like that?
I'm slightly disagreed.
Okay.
We're warming up now. That's good.
Because at present, in my opinion, it's too early to have a clear differentiation of treatment according to prognostic factor.
Okay.
It's still slightly early. I think there is some data, but the data will come around. We'll wait another 20 years and finally. But certainly, I think we have some data, but they are slightly early. So for us, we basically stratified mainly for the age, and the major differentiation is the free versus the two drug. But I do agree that today the free drug combination is mainly, once again, a bortezomib backbone plus alkylating agent, and we are moving from melphalan to cyclophosphamide. On the other hand, where there is the availability, the third drug is an IMiD.
So would either of you like to comment on this idea of adjusting for the prognostic factors?
Yeah, I think for 14, I would go for a proteasome inhibitor. I think the data, both from the United States, just to give some examples, the Total Therapy 2 versus Total Therapy 3 program, they did not versus they did include Velcade. And looking at patients that did have versus did not have 414, there's a difference.
Right.
After the introduction of Total Therapy 3, there was no difference between having 414 and having it versus not having it. But in the old days, there was. Also, there are studies.
Well, this is kind of some of the data that Jesus was trying to present. That when you look at it collectively, that you start to see these patterns.
So I don't know. I think also the French have showed from their trial. So to me, that impacts my way of thinking.
May I discuss this point?
Of course.
The issue is that when you compare good with high-risk patients, standard risk with high-risk patients, you are comparing two different issues.
Okay.
When you compare within the high-risk patient, given the same, the difference is slightly, but the difference becomes even more important with the standard risk.
Right.
So the issue I would discuss here is that things should be compared within an homogeneous patient population. Otherwise, things might become...
And I think this is a good point, and I think that the data analysis that we have is deficient in this way, that it really hasn't been properly designed to assess this correctly. But so
one other point that actually Joe may want to comment on is that the M-SMART algorithm is evolving to treat hyperdiploid and non-hyperdiploid myelomas in the standard risk category differently. So RevDex, IMiD-based therapy is being preferred in the hyperdiploid patients.
Right. This is another area that I don't think that we can get into right now, but it is getting very complex. Looking at if you have 414 alone or 414 with trisomy, or it gets to be really difficult, and maybe we need to be looking to move over to GEP or some other way of looking at it in a more precise way.